In this particular section, we are going to deal on hypersensitivity pneumonitis, which is also a type of ILD in general, but it may not lead to ILD, especially if the cases are reversed in acute stages itself, but in chronic stages, it might go to a stage of ILD. But what is hypersensitivity pneumonitis? It is also an occupational lung disease, but it's typically due to exposure to organic dust. So especially from your bacteria, birds, some organic dust, you're going to get exposed. So what are the general features of hypersensitivity pneumonitis? The first important thing that you have to note about this hypersensitivity pneumonitis is the fact that it is not a type 1 hypersensitivity reaction. The moment you see this hypersensitivity, you tend to think this as a type 1 hypersensitivity reaction, as an allergic reaction. It is not. It's not a type 1 allergy, it is something different, which means there will be no eosinophilia. At the same time, these disorders are not going to have a normal Ig, which means these disorders are not going to have a elevated Ig levels, like what you see in a type 1 hypersensitivity reaction. Very, very, very important point for exams. So what is the hypersensitivity involved here? The hypersensitivity involved here is type 3 hypersensitivity reaction or a type 4 hypersensitivity reaction. And again, it depends what is common and where. So acute hypersensitivity pneumonitis, you'll have a type 3 hypersensitivity reaction, whereas in a chronic hypersensitivity pneumonitis, it's going to be a type 4 hypersensitivity reaction. Now, let us see some of the important interesting features. The first one, this disorder is very common in non-smokers compared to the smokers. Almost 90% of the cases who are affected with hypersensitivity pneumonitis are non-smokers. Very, very rare, isn't it, to get a lung disease that is common in non-smokers. The reason is because smoking sensitizes your airway and your alveoli. And usually your airway, alveoli and the macrophages generally doesn't respond to a new irritant because they are already exposed to an existing irritant called a smoke, cigarette smoke. So they do not generally respond to a new irritant like your organic dust. So that's the reason why it's very common in non-smokers in comparison with the smokers. Then, what are the reasons, what are the source of these antigens that might result in different hypersensitivity pneumonitis? The names are different, but still it's a generalized term, hypersensitivity pneumonitis. Let us see what are the antigens that are responsible. Now, you have a lot of animal protein related things that can lead to hypersensitivity pneumonitis. The first one and the most important animal protein is a avian protein. So whenever you get a hypersensitivity pneumonitis because of these avian proteins, that is referred to as something called a pigeon breeder's lung, or otherwise referred to as a bird fancier's lung. Clear? So then you have plant material that can result in hypersensitivity pneumonitis, like certain plant proteins, which is referred to as Xylophilus lung. Then you also have certain chemical substances that can also cause hypersensitivity pneumonitis, like isocyanates. This is referred to as chemical workers' lung. Clear? So the next is the biggest group that is caused by microorganisms. Lot of microorganisms. The most important of the all, and they're going to ask in the exam, is this thermophilic actinomyces. Thermophilic actinomyces. And there are a lot of microorganisms that come under this thermophilic actinomyces group. What are the microorganisms? One is called Saccharospora rectivirgula. Second is Thermoactinomyces vulgaris, that's called Thermoactinomyces vulgaris. And the third one, you have something called a Microspora fani. Clear? So these are the very important organisms that you have to know. Especially this Saccharospora rectivirgula has been a very, very important question for exams. And this thermophilic actinomyces itself can result in different exposure rates. Like for example, if your exposure is from air conditioners, exposure from air conditioners, humidifiers, and this causes hypersensitivity pneumonitis. This is what we refer to as something called a humidifier's lung. Clear? In the setting of an air conditioner. Second, it can also come from a moldy hay. That is referred to as farmer's lung. Third, it can come from sugarcane hue also. We are going to call that as bagasosis. Fourth one, it can come from moldy compost. We are going to call that as mushroom worker's lung. Mold means mushroom, right? So mushroom compost. So this mushroom worker's lung. Alright. So these are the disorders that are associated with this particular thermophilic actinomyces. Then you have this microorganism like Aspergillus clavatus, typically due to exposure from again mushroom like moldy plants. So this lung we are going to call it as malt worker's lung. And next you can get it from grain weaving dust also. That's referred to as grain handler's lung. Grain handler's lung. And you can get from Mycobacterium avium complex. You all know like this Mycobacterium avium complex causing hypersensitivity pneumonitis is a very common question in exam. That's called a hot tub lung. Everyone knows this. This is a very easy thing. Even microbiology people knows this. And next you have Cytophilus granarius as a potential agent for causing hypersensitivity pneumonitis, and the disease we are going to call it as Miller's lung. Cytophilus granarius. Then you have Cryptospora cortical, and this microorganism exposure can lead to hypersensitivity pneumonitis that is going to be called as maple bark disease. Maple bark disease. This was actually my MLE question. Maple bark disease. Way back in 2007. Fine. Now you can also get with a lot of bacterial endotoxins, especially the people who are working in the cotton industry. And that is very easy to know. In PSM textbooks, it's very common. That's called bicyanosis. Why in PSM textbooks it's given? Because it's common in Indian industries. Cotton industry is very common in India. So bicyanosis. Clear. Next one, it can be due to an organism called Penicillium cc. So this type of hypersensitivity pneumonitis we are going to call it as cheese washer's lung. Fine. Then you also get with another Penicillium organism called as Penicillium nalgiovense. So if you get hypersensitivity pneumonitis because of this Penicillium nalgiovense, it is called as sausage worker's lung. Sausage worker's lung. And finally, only three more is there. In that one is Aurea basidium species microorganisms. If it is due to Aurea basidium species, this is called as sauna taker's lung. Sauna taker's lung. And then you have Botrytis cinereal. If it's due to this microorganism, it's called as wine grower's lung. Then finally, you have Bacillus subtilis. Last one, ultimately it is exhausting list. It's called detergent worker's lung. Detergent worker's lung. Clear? It's actually quite easy to remember if you have some 3 to 4 times of reading. That's more than enough. So in this, the most important in this exhaustive list is going to be very commonly they're going to ask this farmer's lung and bagasosis. Both are due to thermophilic actinomyces. The exposures are different from sugarcane and moldy hay, but anyway, both are due to thermophilic actinomyces. And probably they might be asking you about this hot tub lung. Again, very important for exam due to Mycobacterium avium complex. then bicynosis, typically cotton industry, resulting from bacterial endotoxins, and finally, I think maple bark disease, that is Cryptospora cortical. So these are the some examples of exam questions, but right now I think we are moving towards a more clinical pattern kind of examinations rather than this one-liners. It's used to be very, very common when they are going to ask this one-liner kind of questions. But right now, since they are moving on towards, so knowing all these things, I don't know how much it's important. At least whatever I have shaded here, at least please remember that for exams and move on. So after seeing this exhaustive list, let us go on the clinical features. Go on to the clinical features of hypersensitive pneumonitis. First one is the acute hypersensitive pneumonitis, and second one is subacute to chronic hypersensitive pneumonitis. Let us again, it's like a silicosis only in a way if you understand, but let us see what is going to happen in these patients. In acute, the exposure levels tends to be very high, like what you saw in acute silicoproteinuria, like that. You can imagine something like that, but it's completely different. Acute, like hypersensitive pneumonitis, the exposure rates are going to be very high from the antigen. But whereas in subacute chronic cases, typically it tends to be low to moderate. And timing, usually it happens within 12 hours of exposure, typically around 4 to 8 hours from the time of exposure. So they get these symptoms. But in acute, subacute to chronic illness, hypersensitive pneumonitis, it happens after months or even years after exposure. A very long time it takes. The hypersensitive reaction that's going to happen in acute hypersensitive pneumonitis is going to be a type 3 hypersensitive reaction. Whereas in subacute to chronic, it's going to be a type 4 cell-mediated hypersensitive reaction. Clear? And symptoms are going to be the same almost. So there's no point in differentiating from the symptom's sake. They're going to have a shortness of breath. They're going to have cough. Typically, they will have dry cough. And many of these patients experience this fatigue. And they also tend to have certain inspiratory crepitations. Depending on whether it's acute or subacute chronic, it might be the nature of the crepitations might vary, but you're going to get inspiratory crepitations only. Remember, fever is very common in acute hypersensitive pneumonitis, whereas it can be present or may not be present. It's a little bit rare in case of chronic hypersensitivity pneumonitis. Similarly, weight loss is going to be a feature of chronic hypersensitivity pneumonitis, whereas it's very rare in acute hypersensitivity pneumonitis. You don't generally get, because how can you tell weight loss when they're present within 4 to 8 hours? So that's illogical. Even the textbooks give rare. It's not possible for the patient to present with the weight loss if they're going to present within 4 to 8 hours of exposure. Clear? So now we are going to see the CT appearances. What are going to be the CT appearances in these patients? Again, CT appearances are going to be classical for both. You are going to see a lot of ground glass areas, lot of ground glassing areas. Because of these ground glassing areas may be so haphazard, it might also look like a mosaic pattern. I think I have told you this point in the basics of ILD, that overview of ILD lecture itself, where I have told you this mosaic, first thing you have to think, at least in India, is a hypersensitivity pneumonitis. The moment they give ground glass mosaic is equal to hypersensitivity pneumonitis only. Fine. But there are some other features in the CT scan that you have to know. Like, they also tend to produce centrilobular micronodules, which is again very non-characteristic. Centrilobular micronodules can be seen in many other conditions. We have seen in talcose also, isn't it? So, and silicose also sometimes can produce. So, you cannot tell it's a definitely your hypersensitivity pneumonitis. Only the history along with the clinical examination, along with the history of exposure if you find out, and along with it if you have this CT appearance, then it becomes relatively specific for hypersensitivity pneumonitis. But remember, subacute to chronic cases have one additional finding that you don't have it in acute cases. Subacute to chronic cases will have this interstitial thickening also. Interstitial thickening and fibrosis in the involved areas. This is very, very important. Interstitial thickening will be there. This will not be the case in the case of acute hypersensitivity pneumonitis, because whenever you have an interstitial thickening means it's their progress towards ILD. Whenever they have fibrosis means it's definite ILD, which means surely this is a chronic case only. It cannot be an acute case, because this interstitial thickening and fibrosis and all cannot happen in acute cases for sure. It's a chronic process. And which zone of the lung, which lobe of the lung is more prone for hypersensitivity pneumonitis? It's typically in the mid to upper zones. Mid to upper zones. In exam, they'll expect you this upper zone involvement. But remember, it will spare the extreme areas. Spares the extreme areas means the extreme apex will be spared. At the same time, the basal areas also will be spared. So this is one characteristic feature of hypersensitivity pneumonitis overall. This is also very, very important. Fine. Then how you are going to treat these patients? Treatment of these patients with acute hypersensitivity pneumonitis, just withdrawal from the exposure. Withdrawal from the exposure. So once you make these patients withdraw from the exposure, the symptoms typically will resolve within a couple of days, maximum by 40 to 72 hours. That's it. So withdrawal from exposure is the key. But if the patient presents a subacute chronic hypersensitivity pneumonitis, then you can try steroids, but only limited response you will get, and avoidance of further exposures. This might at least prevent the disease from progressing into a full-blown ILD and fibrotic stage. So you have to avoid the exposure. At the same time, you can try steroids, but with a very variable response. You may or may not respond to steroids, depending on the level of irreversibility. That's depending on the level of architectural distortion and fibrosis, steroids may or may not work. But remember here, you have a ground glass appearance. If you have this ground glass without architectural distortion, they will definitely work, steroids, to an extent. But if there is a ground glass appearance, but still with architectural distortion, means the steroids are not going to work. Clear? So how will you suspect in exams? And in exam, it's one of the very difficult thing to find out. Remember, if the patient presents with recurrent flu-like symptoms, this is the key. Recurrent flu-like symptoms. Whenever the examiner gives you this history of recurrent flu-like symptoms, always think about hypersensitivity pneumonitis. This is a very, very important clue. Clear? Most important, because you have to know in exam how to find out. This is the gold. This is the key. This is where your money is in exam. Recurrent flu-like symptoms. Think about hypersensitivity pneumonitis in exams. Clear? Then what is the response? Th1 response is most important for developing hypersensitivity pneumonitis than a Th17 group of response. Clear? There is no Th2 response because Th2 response is involved in hypersensitivity, for type 1 hypersensitivity reaction. That's Ig, eosinophil mediated reaction, but it's not involved here. It's either a Th1 or a Th17 mediated reaction. Fine. At the same time, I told you Ig levels must be normal, and in this disease, eosinophil levels will be normal as well. And typically, this disease is going to target the smokers than the non-smokers. And very, very importantly, your bronchoalveolar lavage finding is very important. This is again a multiple times asked question. There are two diseases, that's sarcoidosis and hypersensitivity pneumonitis. These are the two cornerstone areas in exams where they'll ask you regarding BAL, where in hypersensitivity pneumonitis, you will see elevated lymphocytes. Often it will be very, very high. More than 50% of the differential count will be purely lymphocytes only. But you will take the CD4, CD8 ratio, and if you see, it will be less than 1, which means CD8 is actually more than the CD4. Remember, if the CD4 is more than CD8, especially if the ratio is more than 2 to 2.5, then it goes towards sarcoidosis. They will also have elevated lymphocytes only. But this in exam always goes towards a hypersensitivity pneumonitis. Again, a very, very important ratio that you have to know. Finally, there are some complications that can happen with, especially with the chronic form of hypersensitivity pneumonitis, not with acute form. Chronic form of hypersensitivity pneumonitis, you can get a complication. I told you, it's going to be centrilobular nodules, right? So sometimes because of centrilobular destruction, air trapping there, you might result in a emphysema. Clear? Or because of the septal thickening and fibrosis, if it becomes severe, they can go for a frank ILD. That is a fibrosing lung disease. This emphysematous phenotype is very common in farmer's lung kind of exposure. Whereas this ILD and fibrosing type is actually common with exposure to bird-related antigens. So this also is very important to know. So the complications are two things. One, they can go for emphysematous transformation, or they can go for a ILD, that is fibrosing lung disease, or they can go for both also as a combination. In general, The emphysematous phenotype is more common with farmer's lung phenotype, and your ILD and fibrosing lung disease is more common with exposure to bird antigens. So let us see some of the images that are associated with hypersensitivity pneumonitis. So this is a typical CT image that you're going to see, and this is a biopsy image that is associated with the hypersensitivity pneumonitis. In the CT, you can see a lot of ground glassed areas. Here, these are ugly areas you can see. Partially displaced air from the air spaces. These are all ground glassed areas. And coupled with that, you have a lot of normal interspersed areas also. Normal attenuation and a lot of variable attenuation areas are there. So this kind of ground glassing opacities or ground glassed areas with in between interspersed with a lot of areas with variable attenuation is what we refer to as a typical mosaic attenuation pattern. One of the important things that I told already in the ILD basics video about mosaic attenuation is the hypersensitivity pneumonitis diagnosis. Plus, this will be associated with formation of centrilobular nodules. Centrilobular nodules, where you can see the centrilobular nodules in many areas. These kind of ugly nodules you can see here. These are all centrilobular nodules only. So this is another centrilobular nodule. So you can see I've enclosed with blue, but there are a lot of centrilobular nodules actually. So a lot of centrilobular nodules you are seeing along with this mosaic attenuation. So this is typical of a hypersensitivity pneumonitis. And here I don't see any much septal thickening or interstitial fibrosis. So it must be a relatively acute case. I have to again confirm with the history anyways. And this is the biopsy picture where you can see a granuloma. There are two granulomas here. These are loose granulomas, typically seen near the bronchiole. Usually typically seen near the bronchiole. This is a typical biopsy picture of a hypersensitivity pneumonitis. CT is very, very important to understand. Clear, especially that word mosaic attenuation pattern with centrilobular nodules. Clear. So with this, I think we can complete the hypersensitivity pneumonitis. In the next section, we'll be dealing with ILD due to unknown causes. Most important in that is the sarcoidosis.